Thank you so much, Dr. Ahmed, and thanks for the scientific committee for choosing my abstract to be presented today. Today, my talk will be on the molecular operation AML and MDS in Kuwait. As we know, AML is a group of hematological diseases, and I say group because they are different phenotypically and genotypically, and the AML, as we know, is a heterogeneous disease. And the molecular abnormalities are not well described in our region. Therefore, we're aiming here to describe the molecular operation in AML and high-risk MDS, and to assess the cytogenetics and molecular correlation as well, and to further extent assess the effect of molecular operation on the outcome, for example, the overall response rates, the leukemia-free survival, and overall survival. Over the last couple of years, and from 2014 to 2020, we had around 230 patients of AML referred to Kuwait Cancer Center, which is the only cancer center taking care of AML and malignant hematology. The median age of that group was 45. We tend to have a younger population than what's reported in the Western, and we have almost 52% of those were male. We have almost in Kuwait like 30 to 35 cases per year. The method here, we collected the clinical cytogenetics and molecular data prospectively since the introduction of the myeloid gene panel test in 2021. And we included patients aged 16 years and above with AML, APML, and MDS with XS+2 treated at Kuwait Cancer Center. This is a panoramic view of AML, and we can see that the AML is, again, a heterogeneous disease that carries a lot of mutations, and in average that the AML patients might have around 10 mutations at a time. And this is the mean myeloid assay that covers a lot of hotspots in the genetic abnormalities that we're targeting. And these are the hotspots that are tested, the APL, PRAF, CPL, CSF3R, DNMT3A, and etc. This is our molecular lab at Kuwait Cancer Center. And this is the request that we are doing. And then we only now doing the DNA-based testing. And then you have to submit the form with the source of the sample, is the peripheral blood or bone marrow. And then you circle the tests that you are interested in. And the results comes like this, with this box that they will tell you exactly the mutations that you circled initially, whether they were present or absent. And then if they discovered any other mutations in the 55 gene panel, it will be reported in the box as well. And this is another CML patient who had 2 APL1 mutations like T315I mutation and E255K. In our lab, we received sample from all the country for every patient with myeloid, suspected myeloid malignancy, for example, the polycythemia vera, ET, myelofibrosis, MDS, etc. And we received it from both pediatric and adult patients. We have around 10 to 15 cases per week, with a very good turnaround time of 10 to 14 days. And today our focus will be the AML, MDS, and the APL as well. So the results are followed. We had 472, and 57 of those were the target population that we're assessing, the AML, CML in myelodysplastic crisis, the MDS, and APL. If we look at the basic demographics, the median age of all 57 patients is around 52. We have a 60% of those are male, and almost 40% of those patients are reflecting the basic demographics in Kuwait. We had 73% of those cases were de novo AML, and 5% were relapse AML. We had 4 cases of APML, and 6 cases of MDS EP2, and 2 cases of CML myelodysplastic crisis. And these are the median WBC, hemoglobin, and platelet and peripheral blast count. On the cytogenetics, we have the data on 49 patients, and the rest had a failed cytogenetics. 70% of those were diploid cytogenetics. We had 821, trisomy 8, and other high-risk features like complex chromosome 3 and 5 or 7 abnormalities. If we look at the treatment outcome for patients treated for AML or MDS, we usually give them the anti-AML therapy. We usually give the UK protocol, what we call a DA10, 10 days of RSE and 3 days of daunorubicin. Or sometimes we go to a flag, and this is mainly if the patient has some cardiac abnormalities. And we look at the CR rate is around 60 to 67%, and almost 30% of the patients were refractory to the intensive chemotherapy. If we talk about the hypomethylating-based regimen, we have 13 cases treated with HMA-based regimen. A7 were 10 patients, plus minus FLT3 inhibitor in 2 cases, one with gilteritinib and the other with midostaurin. And 1 patient had tyrosine kinase inhibitor ponatinib for a AML myelodysplastic crisis, in whom he had a T315I mutation. If we look at the CR/CRi rate, it's very impressive, 91.6%. And 1 patient had a refractory disease, and 1 patient was not evaluable because he traveled to his home country. 1 patient had a low-dose cytotherapy, and it was refractory, and 6 cases were not treated either because they were sick enough not to receive treatment, or they decided to go back to their hometown country. For the 4 APML cases, all of them were treated with ATRA-ATO plus minus idarubicin, and the CR rate here we can see 100%. And this is the number of mutations. At least 85% to 90% of the cases had at least 1 mutation, and only 6 cases did not have any myeloid gene abnormalities. If we look at the type of mutation here, the FLT3 was the commonest mutation, followed by NPM1 and DNMT3A. PTPN, which is one of the tumor suppressor genes, was positive among the top 5 mutations listed here. And this is also reflecting from the Atlas of Cytogenetics for AML patients. We can look here that FLT3, NPM1, DNMT3A were the most common mutations in AML patients. If we look at the mechanism of the mutation, that we can find that 27 cases had an activating signaling pathway abnormalities, and DNA methylation was in 25 cases. The chromatin spliceosome was in 19 cases, and 10 cases had tumor suppressor abnormalities. Now, with the focus on FLT3 mutant AML, we had 14 cases. In AML, we had 12 cases. 10 of them had an ITD abnormalities, and 2 cases had D835 mutation. The allele burden was around 25%, ranging from 1 to 50% almost, and for the D835, it was around 17%. Half of the FLT3 mutant AML had NPM1 mutation, and almost 30% had DNMT3A, and 1/4 of them had TET2 mutation. If we look at the treatment given to those patients, the AZA venetoclax in 3 cases, and all of them had complete remission at day 28. And for the 9 patients, they received DA10, and the CR rate was around 71%. And 1 patient did not receive, 1 patient had passed away during the induction. For the APL, surprisingly, 2 patients had FLT3 mutations, and 1 had both ITD and DA315. And the allele burden, as you can see here, and treatment, as we said, it's ATRA-ATO plus minus idarubicin. For the NPM1 mutated AML, we had 12 cases.
One more minute, Ahmed.
Okay, I'm finishing, Dr. Ahmed. All had diploid cytogenetics and had co-mutations ranging from 2 to 4. Half of them had FLT3 abnormalities, and half of them had DNMT3A, and 11 patients were treated. If you treat them with azavan, the response rate was 100%, and if you treat with chemotherapy, it's around 87%. And for 821, we had 5 cases. All of them had some mutations, 1 to 2, and this might reflect why our patients in 821, they don't do well as Western population. So in conclusion, this is the first comprehensive, to my knowledge, molecular abnormality report in AML in our region. Almost 90% of the patients had myeloid gene panel. FLT3 mutation followed by NPM1 was among the most common abnormalities. Patients with A21 AML, all of them had at least one mutation, and this might explain the lower rate of leukemia-free survival and overall survival in comparison to the reported literature from the Western experience. A7 resulted in a higher complete remission rates in our experience, especially for those with NPM1 mutant AML. All patients with AML had at least one mutation. However, this did not impact the remission rate when treated with ATRA-ATO. With that, I would like to conclude and thank you so much for listening. And I would like to thank my group in the Department of Hematology, Hematopathology, Flow Cytometry, Molecular, and our secretary as well. Thank you so much.